Palpation of the scapular spine and the acromion. Superior border of the clavicle. This is where we are going to search later on the suprascapular vein. The design of the skin island is centered in the acromioclavicular angle, and it can be extended backwards towards the scapular region below the spine. We begin cutting the skin island deep enough to get to the deltoid muscular fascia, which stays on the flap. When elevating flap with bone, the design is more posterior, and the supraclavicular vessel branches are being divided. The medial edge of the skin island is being cut, and this is where the vascular branches of the pedicle are running through. So the platysmal muscle must stay on the pedicle. Here it's going to be divided for demonstration purposes. A cervical collar incision is performed above the formalization wound. The cervical skin flap at this level is elevated in a plane deep to the platysma muscle as usual. Now we are going to connect the cervical incision with the skin island by means of an S-shaped Z-plasty type incision, which will later on facilitate wound closure. In the inferior half of this incision, the platysmal muscle stays on the pedicle. Now we're going to elevate a posterior cervical skin flap in order to expose the superficial aspect of the trapezius muscle as far as the medial aspect of the scapular spine. The posterior segment of the skin island is being outlined, reaching in depth to the fascia of the deltoid muscle, which must stay in the flap. The skin island paddle has been elevated all the way up to the medial border of the scapular spine, of which is going to be detached the deltoid muscle by cutting on the bone. When we elevate just the myocutaneous flap, the deltoid is not detached. Now, when elevating a fasciocutaneous or myocutaneous flap, we can preserve the spinal accessory nerve, which must be investigated close to the anterior border of the trapezius, where it runs superficially until it dives to penetrate the muscle through its deep aspect. It can be mistaken for the sensitive branches of the superficial cervical plexus, but it can demonstrate it by means of a neurostimulator or by gently pinching on the nerve with a hemostat, making a muscle to twitch. Beware the curarization may block this test, and in such case, the nerve should be followed all the way up to its entrance into the trapezius muscle. This is a simulation performed in the cadaver. Here, we are elevating the inferior and anterior cervical skin flap, living in situ the platysma, and exposing the clavicle and the proximal attachments of the pectoralis major. The tissues covering the clavicle are being divided until we reach the bone without scraping it. Then, we're going to elevate these tissues upwards in order to expose the posterior aspect of the clavicle until we reach to the subclavian muscle. All the tissues, fascia, fat, and vessels are going to be pushed gently upwards, leaving behind the subclavian muscle as a landmark. We continue freeing towards the acromioclavicular angle, dividing the attachment, the clavicular attachment of the trapezius, and freeing the skin island all the way up to the acromioclavicular joint. At this level, it is possible to identify the suprascapular vein, which is the most outstanding structure. From here on, and with a digital maneuver, all the tissues that form part of the pedicle, including the suprascapular vein, are pushed upwards. Without skeletonizing the vessels, they are being freed up medially all the way up to the external border of the sternocleidomastoid muscle and laterally all the way down to the inferior aspect of the acromion. We remark here the large volume of the triple vascular pedicle, which is being held between fingers and whose width goes from the clavicle up to approximately the point where the spinal accessory nerve enters the trapezius. Now, a finger maneuver is being used to detach laterally under the acromion to fully liberate the soft tissues from the clavicle and the superior aspect of the acromion and the joint. In depth, we can now palpate the coracoid process, which is the most important bony landmark at which base the suprascapular nerve and suprascapular vessels can be found. More detail about the exposure of the acromioclavicular joint until it's going to be divided. If just a myocutaneous flap would be performed, at this level already the trapezius muscle should have been detached from the scapular spine going medially. Now we are going to identify the suprascapular nerve and the suprascapular vessels where they are related to the base of the coracoid process. Close to the nerve, we are exposing here the suprascapular vessels, which are going to be ligated and divided before they run into the periscapular arterial circle. They should be ligated as low as possible in order to preserve the branches that run into the flap and that have their anastomosis with the triple pedicle. We also ligate and divide other innominate vessels that go on top of the supraspinatus muscle in order to complete the liberation of the pedicle. Finally, the posterior belly of the omohyoid is being divided, which is running through the flap pedicle. We keep pushing the pedicle upwards with digital dissection, leaving at the bottom the dip cervical fascia through which the intact brachial plexus can be seen. The suprascapular nerve is being lifted just for demonstration purposes. The deltoid muscle had already been detached, and now the supraspinatus muscle is being digitally separated from the scapula before performing the osteotomy. The supraspinatus muscle had already been separated from the scapula by digital maneuver, and we are holding the base of the acromion before sectioning the acromioclavicular joint. Division of the capsule and fibrous tissue of the acromioclavicular joint with the scalpel. Now we can free up the inferior aspect of the acromion that can be performed with a scraper and dividing ligaments. Division of the acromioclavicular joint with shears before the osteotomy. The osteotomy line on the inferior aspect of the spine can be visualized by easily retracting the infraspinatus downwards. The osteotomy is begun from the base of implantation of the acromion downwards toward the medial end of the scapular spine. The simplest way to do it is by means of a reciprocating saw. The plane of the scapular osteotomy is much more superficial than the rib cage, for there is no risk of a lesion at this level, and the bone cut is performed under direct vision. The ligaments holding the bone are being divided, as well as some tendinous attachments. With the acromion plus the spine, 14 to 17 centimeters of bone can be harvested according to the size of the patient. In depth, at the union of the lateral with the inferior aspect of the trapezius muscle, there is a tendinous expansion which attaches to the medial angle of the scapular lamina. This is cut with shears in order to liberate and free the flap and thus complete the osteotomy. The posterior cervical skin flap is elevated further in order to expose completely the lateral trapezius, and then we are going to be able to divide the muscle at this level. The supraspinatus muscle is being separated from the deep aspect of the trapezius, such a way that we can keep elevating the flap upwards. We continue liberating the flap pedicle from the deep plane of the lateral neck. Now we're going to perform the trapezius myotomy from its anterior edge backwards all the way to the medial end of the spine. We cut through the full thickness of the trapezius muscle down to the fascia that separates it from the lateral neck muscular plane. With such muscular volume, the spinal accessory nerve cannot be preserved. We keep liberating the pedicle and the trapezius muscular mass from the deep plane of the neck. We can see here now how the levator scapulae is being separated from the pedicle. All the innominate vessels which do not anchor the flap can be preserved. Here we can see the width of the pedicle containing the vessels. The head of the patient can be flexed and rotated towards the side of the operation in order to avoid tension on the pedicle. Flap positioning is being evaluated according to reconstruction requirements. If the anterior segment will be reconstructed, a wedge resection of the bone can be performed to shape an angle and get a better forward reach of the bone. We here demonstrate how to elevate and rotate the head in order to avoid tension on the flap pedicle. Replacement of the inferior gingiva, floor of the mouth, and skin of the chin can be performed with the same skin island. For this purpose, the portion of the skin island that is going to be sutured to the raw surface of the inferior lip is going to be de-epithelialized. We repair the donor side of the flap, suturing the detached deltoid to the spine and the acromion to the lateral end of the clavicle. Then we suture the trapezius muscle stump to avoid bleeding, and we reapproximate the supraspinatus with the infraspinatus and this to the deltoid muscle.